Welcome everybody. Thank you for coming to our CPC Friday seminar and braving the crazy snow out there.
Dangerous snow.
I know, dangerous conditions. I'm glad so many people could make it to listen to the talk by my friend Alison Buttenheim, who's joining us from University of Pennsylvania. Alison earned her PhD at UCLA, and two of her committee members are actually in the room. Dr. Duncan Thomas and our own Elizabeth Frankenberg was on Alison's committee. She was a postdoc scholar with the Robert Wood Johnson Foundation, the Health and Society program. She is currently an associate professor in the Department of Family and Community Health and has a secondary appointment in the Division of Health Policy and at the University of Penn. She has a few other hats. She made me cross some of these out. She said, those aren't interesting. I thought they were, but she is the Associate Director at the Center for Health Incentives and Behavioral Economics, as well as the Director of Engagement for the Leonard Davis Institute for Health Economics. She has 76 peer-reviewed publications, including 4 with me in 2019, and we have about 4 or 5 under review or submitted. We get along marvelously. Alison wears many hats like myself. We have our areas of interest, but I actually went through and jotted down some of the topics of your papers.
Concept map?
A little bit,
cool.
But I just thought it was super cool because we have Chagas disease, vector control in Peru, healthy food purchases in a grocery store cashback program, assessment of exemptions from vaccination in California. We want to do that. Disparities in HPV vaccines, transforming mental health care delivery, Botswana cervical cancer screening program, survey recruitment for hard-to-reach pregnant smoking population. Lots of different study topics, really interesting stuff. Alison is currently PI or co-I on numerous research grants from NIH and the Gates Foundation, and she has completed numerous research projects, both externally and internally funded. She's a great mentor to her students, to postdocs, and to myself as well. I think she wrote me a great letter of recommendation for my K application. So if we can welcome Alison Buttenheim.
Yeah, it's helpful to have someone else tell you that you're working on too many things. Duncan and Elizabeth have been telling me that since the noughts. So this is not going to be a deep dive into one paper, because how would I pick? It's more one of those, like, what is Alison thinking about and worrying about kind of talks. That's given me a chance to pull together some ideas in sort of preparation for a big project we're getting underway in South Africa. So very, very keen to have input from you all, especially if like stuff doesn't make sense, or I think something's a problem and you don't think it's a problem, or I think something's not a problem and you think it is a problem. Definitely weigh in, and happy to have this be conversational, either clarifying or substantive questions as we go. And it's set up so that if we need to skip a bunch of stuff or stop early, that's all fine. Okay, so nudging or fudging. Let me, for those of you who might have to leave, here's the whole talk in like 60 seconds, just in case you manage to leave early. So a lot of interest around the world in behavioral economics, behavioral insights, behavioral science, and sort of nudge units, sort of instantiating that in different sort of governmental and non-governmental organizations, including an effort that I'll tell you about with Harsha Tiramurti, who used to be here, that we're getting underway in South Africa, sort of an HIV nudge unit for the country. Lots of enthusiasm about nudges. Nudges work, yay, you know, except when they don't, or maybe they don't, or maybe they don't sometimes. So all of that has had me thinking about a couple of different ways in which I worry that we're not kind of reaping the full benefits or harnessing the full potential of behavioral science to improve population health. And it's been helpful for me to sort of park those in some buckets, and those are the buckets I want to talk through today. So one is sort of definitional, and this is where the nudging versus fudging title comes from. I think we're calling a lot of stuff nudges that aren't really kind of definitionally crisp about what we're talking about, and that may affect how we think about impact of the field if definitional stuff is fuzzy. I think design of interventions is really, really important and a step that is skipped a lot in the enthusiasm to sort of go start nudging stuff. We sort of skip over really important work that can really be informed from the field of design in thinking about interventions. Sort of a heterogeneous treatment effects problem, sort of an apples and oranges. When we have null effects, we have negative trials, we don't always have the capacity to kind of look under the hood and see, oh, actually this did work pretty well for some people and not for others, or mechanistically this intervention is sort of working differently than we thought. And I think we're, again, not going to kind of reap the full potential of the field until we do that. And finally, a whole host of questions around scale and implementation. And when we find stuff that works, how do we get it into practice, and how do we scale it up? So I'm done. That's pretty much the whole talk there. Let me read the room. I was warned by Harsha, who spent several years here in the as an economist in the health policy department, that there might be some nudge skeptics in the room. So I want to assess both kind of familiarity with the field and also enthusiasm for it. So is there anyone who's like a total nudge neophyte, hasn't really heard the term, hasn't worked in the space at all? Thank you for admitting that, Exeter sweatshirt guy. Great, so anyone, feel free, okay, lots of people, great. Like there was nudging and fudging on the title and I really had no idea what you're talking about, great. And who is like firmly in this space? Like I do behavioral science, I have papers about this, I'm well versed in the literature. I won't call on you, I promise. Audrey, you gotta be in this. Okay, so most of you are sort of somewhere in the middle on that, great. And then this maybe is a harder question to answer if the familiarity is lower, but on the axis of like, I'm pro, like I think this is probably a really good idea, like yay nudge. Good, okay, God, is the social norms going on here? And then like, I'm definitely a nudge skeptic. Like you're gonna have to convince me this is something worth investing in. No, at least self-reported. Okay, that's really helpful.
But you didn't ask the question, Alison, about do you think that every nudge study was worth doing and has been informative? And on that, you would have lots of skeptics.
Absolutely, absolutely. And that's definitely true of myself as well.
So, yeah,
that's a hard standard to hold folks to. So just to level set, let's start with the definition. I'll start with Sunstein and Thaler's. They wrote nudge over 10 years ago. Pretty helpful definition. An intervention that changes any aspect of the choice architecture, sort of a term they coined, to alter people's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. The idea of sort of light touch, often low cost ways of sort of tweaks, tweaks on the margin. And then there's this idea of like in a predictable way. So what do we mean by that? That means what can we take from a whole host of insights that behavioral economists like to call behavioral economics, but social psychologists, cognitive psychologists, lots of other fields know are also from those domains about ways in which we make decisions using heuristics, using sort of rules of thumb or shortcuts, and ways in which our decision making might be biased that are very predictable, very sort of easy to observe in lab settings and in the field, and it can be harnessed in interventions or can be addressed through intervention design. So we're boundedly rational, right? We don't work like Homo economicus. We actually have very different ways of sort of bumping up against sort of rationality bounds. We are often making decisions under cognitive loads or emotional loads or attentional deficits, and bump up against those limitations. We are limited in our self-control as human creatures. And while Homo economicus always has access to all this perfect information, we know that in reality, that information is often imperfect or incomplete, or actually so overwhelming that we can't attend to it. So like that's the context in which we had these sort of predictably irrational, to use Dan Ariely's terms, ways of making decisions that affect our behavior that can be kind of leveraged or harnessed in nudge approaches. The other context study I want to do is where we're headed for this project in South Africa, because these are really why I'm trying to ask and answer some of these questions. So Harsha and I, really led by Harsha's prior work in other parts of the region, have just been funded by the Bill and Melinda Gates Foundation and in partnership with a fantastic group in South Africa called HERO. We're basically asked to build capacity in South Africa, primarily for now among the HIV services delivery and research group, but maybe to expand to other disease groups, in applying behavioral science to health services delivery. The initiative is called INDLELA, a Zulu term meaning the way or the path. Our sort of tagline is behavioral insights for better health, and it's going to look like capacity building workshops. So, hey, researchers in the country, hey, folks who implement all these HIV programs under PEPFAR and under the government, come learn from us about nudges, nudge approaches, behavioral insights, behavioral science, and then have access to a big pot of sort of pilot funds to actually try this stuff out. So yes, we want to get a lot of projects run, but more importantly, from sort of a sustainability standpoint, want to build enduring capacity in country to look at problems from this lens and bring that expertise. So that officially launched January 1. It's initially a 3-year endeavor, $4 million grant from Gates. So when you hear me sort of toiling at the rock face of some of these questions, it's for INDLELA that we're trying to answer them. And in terms of that, in terms of this being sort of situated in the context of HIV, you know, why do we think this is something where behavioral science, behavioral economics even has something to say? In some ways, South Africa is a unique context for the HIV epidemic, in some ways not, but like other countries, very focused on these 90-90-90 targets. This is not anymore a problem of like trying to get people to use condoms and avoiding risky sex. This is about getting people to know their status through testing, initiating treatment if they're positive, and staying on treatment, being retained in care to get their viral load suppressed to a point where they can't infect other people. So it's behavioral in terms of sort of accessing these services and staying in care. And from the epidemiological models, we know that if we can hit these targets, they're all now also 95, 95, 95 targets to sort of fast track things, we can actually get incidence below where it is now and curtail the generalized epidemic. So, you know, are there still structural barriers to HIV services in the country? Yes, there are. Are there still sort of socioeconomic and gender contexts that make this, you know, a tough epidemic to tackle? Yes. Are those solved by nudges? Rarely. But there definitely is this kind of last mile behavioral challenge to get people to test and link to care and retaining care. This is where the focus of INDLELA will be.
Alison, where does PrEP fit into this?
In the 90-90-90 targets, not, but also a growing interest in country. So one, you know, PEPFAR has made these services free and widely available. PrEP is not yet like available to anyone who wants it. It's still being focused on sort of key populations, but we're getting there slowly. And I'll talk about some of our sort of pharmacy solutions that might be able to involve PrEP as well. So let me pivot to sort of unpacking this like enthusiasm for nudges, and is there any evidence that these things work? And again, by nudges, we mean these sort of low cost, usually light touch interventions that change the choice architecture, and incentives, financial incentives of a small size have been part of that conversation all along, even baked into our name, Center for Health Incentives and Behavioral Economics. So I've just pulled 3 examples. They sort of go in temporal order. I pulled them because they already exist in my teaching slides and I had access to them. But they're good examples. So this is Rebecca Thornton's paper from over a decade ago, doing an RCT in Malawi on small financial incentives to encourage people to do testing. And you can see sort of the main effect on the left, and then sort of interesting things about this, does the size of the incentive matter? Always a question, right, with these sort of metric approaches, like if it's a little bit of money, does double a little bit of money do better? Things like that, but a very nice, strong main effect. Fast forward a couple of years, Esther Duflo and Hamjeet Banerjee, who just of course won the Nobel Prize. I love this paper. This is a great teaching paper. This is a paper on incentives in the form of lentils and sort of metal plates in rural India for getting parents, mostly moms, to get their kids vaccinated. And the nice thing about this was they were also able to test sort of a structural version or a structural intervention where they also guaranteed that these immunization camps would be sort of open and running. So, one barrier is that, mom's not going to take half a day to schlep, a couple hours away with the kid to find like the nurses in the clinic that day, or the immunization camp she thought was going to be there was there. So sort of guaranteeing the camps as a structural intervention and layering on the incentives as an additional nudge. Again, nice main effects, and you can sort of see separately how camps alone versus camps plus incentives works on the left. And probably numbers there are a little bit small, but the basic result on the right is that these are particularly effective at getting those like last sets of immunizations. So you don't see a lot of difference for just getting that first shot, but to complete the primary series for the kid, which is a lot of effort and a lot of visits for mom, the nudges are particularly effective there in making sure the kid has all 5 required immunizations. And then one paper from Harsh's work in Kenya, another important evidence-based HIV prevention behavior, which is voluntary male medical circumcision, comparing incentives of different sizes, sort of a low, medium, and high, and getting a big bump in terms of sort of odds ratios and probabilities on % of men who respond to a financial incentive to do circumcision. If we had like a whole hour to talk about this paper, we could talk about the interesting fact that the low incentive wasn't any different from the control, and it was only at the medium and we're at higher side where we got action, but like that's an interesting component too of these nudge studies, sort of where is the sweet spot of the incentive size, and at what point is this no longer a nudge because it's just, you know, it's just a price change. My colleague David Ash says that's not behavioral economics, that's just economics when we change prices. But you know, those are 3 individual studies. You can also look at a growing number of sort of systematic reviews and evidence summaries across lots of different health domains, lots of different settings. This is a systematic review more from high-income countries than low and middle-income countries of nudges specifically to improve self-management for chronic diseases, mostly diabetes. And I think the summary from this review is a pretty good example of what a lot of these evidence syntheses say. So this review demonstrates that nudges can improve chronic disease self-management, but hardly any evidence to date that these interventions lead to improved disease control, right? So we're getting engagement, we're getting behavior change. We don't necessarily see sort of clinical outcomes that we might want to move. And of course, you know, there's some subtleties here in which kind of nudges. So in this case, reminders, feedback, and planning prompts appear to improve chronic disease self-management most consistently compared to other nudges that were investigated, and are among the least controversial types of nudges. Accordingly, they can generally be recommended to policymakers. So some hint, even just in that abstract, that there are different sort of levels of acceptability, sort of perceptions of acceptability, feasibility, implementability, along both kind of financial and ethical dimensions that have to be paid attention to if we want to see all these things. Again, one of literally dozens of sort of nudge systematic reviews that I could have pulled there. And then there's all the times that nudges don't work. This is my, my first R1, big cluster randomized trial in Peru. The behavior we were trying to change was household participation in a vector control campaign. So basically a household agreeing to have their home sprayed with insecticide to prevent the insect vector that carries Chagas disease. You know, really short story, total null trial. We came up with 3 interventions that were so beautifully designed, behaviorally informed, formative work, pilot testing, really gorgeous, conceptually crisp. One was around sort of scheduling and planning, and can we get people to sort of commit to this spraying ahead of time instead of just showing up the same day and saying, hey, we're here to spray your house. Second intervention around getting kind of leaders, like opinion leaders, block leaders, to recruit households for us instead of the campaign showing up and sort of being the government is here to help. And finally, a contingent group lottery, sort of fancy term for, there's a bunch of houses on the block. We tell them that they're in a group. We give them a number between 1 and 36. We tell them a date of the national lottery poll and say, if your number comes up, you don't win the national lottery, but you get a prize if you have sprayed, and your prize is double if everybody in your group has also agreed to spray. So contingent and group-based. And don't really need to see the numbers by the bars. The darker is intention to treat, the lighter is sort of per protocol or treatment untreated. We did not move the needle at all on this. Beautiful discussion section telling you all the reasons why we think that's true, and some sort of possible explanations. But you know, sort of sad day for us when data spat out the results. That sort of all that effort, and I think sort of doing it the right way in terms of design and formative work, and hearing from the people about what their actual barriers were, that nothing budged there. I can show you these results because they're mine and because we actually got this paper published, but think about all the null trials that are sitting, well, in the old days they sat in file drives, they probably just sit on your computer now, but you know, we don't see the vast majority of the nudges that people test and either don't publish or aren't in the publishing space. So the groups like Ideas 42 or the Behavioral Insights team or all the nudge units that are trying stuff and just don't publish stuff anyway, whether it's positive or negative. So we have a really, I think, skewed view, not uncommon, due to publication bias that we're not seeing some of the negative ones. I'll show you another one just because I'm really good at publishing little trials. This one is a much smaller deal, but like incredibly disappointing results. Here we were trying to get parents who had an infant in the house to make sure they had their Tdap vaccine. This is in Philadelphia, to protect the infant from pertussis. The infant's not fully covered until they've gotten a series of shots themselves. So really important that adult caregivers in the house have that shot. We used both vouchers, so either $5 off the vaccine or a voucher that covered the full cost of the vaccine at a nearby Rite Aid pharmacy. You know, you can get most of your vaccines at most retail pharmacies in the US. These vouchers were delivered at a pediatric practice at the newborn well-child visit. So the baby's maybe a week old, caregivers come in, and they either get like, here's a $5 off voucher, here's a voucher that will cover the full cost of the vaccine, which is about $65. And also randomized to see or not see a very good JLo public service announcement video about the importance of Tdap vaccination for adult caregivers. You know, she's great, she's gorgeous, she talks, you know, very directly about why this is so important. There's music, she hits all the right messages. We just like pulled this from YouTube. And importantly, for sort of salience, if you think about sort of the salience and information provision aspects of nudges, you heard the sound of the infant cough, in the whooping cough, which is a horrible sound. It's sort of like very gasping cough. I mean, that was, you know, like with the heartbeat and with the JLo music, great video. 90 seconds long, highly recommend it. So, so low cost voucher, full cost voucher, see the video or not see the video, randomized about 100 parents, caregivers, and 1% of the 100 people went and got the Tdap vaccine at the Rite Aid pharmacy. Again, really nice discussion section talking about why that might have been the wrong set of nudges or the wrong setting, or just not an effective setting for this nudge, but you know, a disappointing result. And makes you think, you know, is the nudge approach right for this behavior in this population, and did I design it right in the first place? There's been, I think, a growing interest in, I won't say debunking, maybe growing skepticism about these approaches, so much so that Harsha and two of our colleagues at Penn, David Ashton and Bull, actually wrote a perspectives piece in JAMA about, you know, like how uncertain are these effects? Should we be giving up or looking elsewhere for financial incentives in this case, but more generally for nudge approaches? And their conclusion, it's not rocket science, but you know, they said the principle that individuals respond to incentives has considerable empirical support. And again, you can see that in the systematic review literature. However, the magnitude of these effects differs substantially, right, based on the nature of the behavior, check, size of the incentive, check, population involved, design and social context, check. The risk in failing to consider the often defining influence of these seemingly subtle design choices is not just that promising effects might be missed, but that negative studies will unduly influence an entire field. Of course, a bias in and of itself, right? That the people who are skeptical about nudges are going to kind of look for the evidence that they're not working. But interesting to me that they sort of felt that there was so much kind of skepticism and pushback in the literature that it was worth kind of summarizing those points. Any questions? I know I talked about that. Yes.
When does a nudge become a hammer?
Yeah.
You know, so is it just the size of the incentives? You know, you give them a $10 gift card, it's a nudge.
Absolutely.
Give them a $5,000 gift card, it's you know, too good
Great
to
question.
resist.
Yeah, and the rest of you are going to think I planted that question in a couple of slides. So. I did not. And just to say, they wrote that piece on financial incentives, true for other types of nudges too, right? Whether it's framing, commitment contracts, defaults, social norms. Although I gotta say, defaults are probably like the best tool we have in the toolkit. Defaults are almost good. So let me come back and we'll definitely answer this question of, you know, we're at the space where a lot of enthusiasm, growing skepticism, a lot of mixed evidence about whether this is the way to go, and just kind of want to walk through sort of definitional design issues, heterogeneous treatment effects, and scale implementation questions. So let's start with, is this thing that we're doing really a nudge? I put the Sunstein and Thaler definition there again, and this is where sort of, you know, I'm starting to call things fudges or, you know, fake nudges or faux nudges. And what are some ways in which a nudge might not really be a nudge? And one of them is it's just so much money that now we're not like subtly changing the choice architecture or making, you know, usually we think from a behavioral economics standpoint, we think incentives should work because this behavior that we want to do, we want the person to do, has costs and benefits. And at this point, they think that the benefits aren't as salient or immediate or tangible or certain as the costs, which are like my effort or the hassle or whatever to do the behavior or my resistance to it, and the little bit of an incentive is enough to sort of get me over the hump. But if I'm like paying you stacks of cash and I'm just changing the costs and benefits in a way, there's not a number. It's not like a $2 thing is a nudge and $5,000 isn't. You can translate it to sort of purchasing power parity, and you might think once we're at like a day's wages, that starts to be more salient. One way I like to think about it in terms of this being a good example of how we're not rational thinkers. If we think about incentives for smoking cessation, very common intervention, very successful. I'll talk about that in a little bit too. For most people, even people who don't smoke a ton, the money that they'll save just from not smoking immediately exceeds any incentives that we're giving them. And yet, until those incentives are offered, so the salience of like, hey, if you come back and make a nicotine test, we'll give you $45, that ends up being sort of the motivation. And of course, there are interventions where they tell you every time you don't buy a pack of cigarettes, put that money in a jar. No one does that. But cigarettes are expensive, and you very quickly, from a sort of a rational calculation standpoint, are saving more money. And yet, the sort of cleverly designed financial incentive works better. So just all that to say, if there's a lot of money on the table, or if the interventions that's being designed is so kind of resource intensive that we're not just subtly changing the choice architecture, we're designing whole new systems and interventions, we're probably not in that space anymore. Similarly, if it's what people call a shove, right, instead of a nudge, you're truly limiting choice. Like the idea in the Sunstein and Thaler is that we're not absolutely restricting people's choice. We're just trying to sort of nudge them to the choice we want. Once policies or programs or interventions start truly kind of forbidding things or shoving you so hard in one direction, that's probably not a nudge either. And the other sort of faux nudge I worry about a little bit, print is faint there, but has anyone seen this? This is the Behavioral Codex, the Cognitive Bias Codex. It was, I think, a beautiful attempt, and you can buy posters of it, to sort of capture and organize and label all the known biases and heuristics that have been sort of uncovered in this field, again, mostly from social psychology and cognitive psychology, some from economics. And I think with all the sort of nudge enthusiasm, there's sometimes a tendency to just like grab one off the wheel, and they all have great names. They're either named after people, or they have these sort of funny names, and just build an intervention around it and try it. And I mean, it might be a nudge in that it's a way to kind of change someone's decision-making frame, but the sort of lack of context and sort of leading with the solution seems to be a problem. And I think there's so much enthusiasm. We see it at Penn Medicine. People from every clinical domain want to like get on the nudge bus, and often like this is the route in for them. Like, oh, which one do I pick? So I sort of worry again, definition about where we are with that. So that's sort of problem one. Let me talk about design, because again, I think this really matters. So, and I'm going to blame the economists a little bit here, because I think they're sometimes guilty of it more than other sort of public healthy folks. But people do show up with a hammer. I do lotteries, I do defaults, I do social norms, interventions, feedback, audit type things. And sometimes it's a nail that they're whacking on, which is great. Sometimes it's a screw though, and sometimes it's like a cinnamon bun or something. So I think we need to think much more about understanding the problem that we're trying to change before we start rummaging through the toolkit and grabbing hammers versus something else. So we've been sort of instantiating that at Penn in a framework which you'll be shocked to hear is called NUDGE. But it's an acronym. And if you've done any sort of user experience or human-centered design, the steps will sound very familiar, although they have different names. There's sort of a narrow the focus to a really specific behavior you're trying to change. This isn't like end HIV. This is like get people who take a self-test to report their results, and that narrow. Understand the context through inquiry. In the design process, this is the empathize phase, like get out there and talk to people and look at what's going on. And that's a sort of divergent step, right, with the double diamond. Converging to sort of discovering the insights that are underlying that context. So what actually, you can call it a behavioral barrier, you can call it an insight, whatever you want. What is getting in the way of that person reporting that test result? And those are the insights that you use to then generate your intervention ideas. That's what feeds your prototyping process, more than, ooh, I think lotteries are really cool, and Ken Gulp did a really neat one with smoking, so I'm gonna go use that for Chagas in Peru. And then of course, converging again, we want to evaluate that through some kind of hopefully like counterfactual trialing, whether that's like rapid cycle stuff or large randomized trials.
Alison,
Yeah.
That system also described good scientific design.
Yeah, I just think it's
Not
something we
specific
skip
to
a lot, at least in the sort of enthusiasm for applying behavioral science to health. I've just seen a lot of people kind of leading like like showing up.
I'm not just criticizing what you say. I'm just saying I think it's a valuable
Yeah.
lesson for everybody to think about whenever they design a scientific study, intervention or non-intervention.
Yep.
Observationally, yeah.
Yeah, I mean, it's very, very scientific. No citations yet. Papers forthcoming, I hope, very, very soon. Happy to send stuff on that. Let me just give you a couple of examples of how that process leads to insights that can then inform interventions. And I've got lots of examples. I'll please skip some until we have time at the end. But let me tell you about two projects we're working on. One in Philadelphia in the public mental health system. So Philadelphia owns its own Medicaid managed care behavioral health system, where we get to do a lot of work. And one evidence-based practice that we try to implement, sort of an implementation science study, but we want therapists to use evidence-based practices in their therapy appointments. Because, you know, like if you're a trauma patient and your therapist uses trauma-informed CBT, you're going to do better than if they do something else that's not evidence-based. But fidelity and adherence to those evidence-based practices for therapists is pretty low. So the team that wanted to work with us on this came in with their hammer of like, we think incentives might be really helpful here. We think if we just like pay a therapist more for the visit, if they can demonstrate that they use the evidence-based practice, it will get greater adherence. And actually there's money in the system to support EVP implementation, and we can use that this way. We thought that's okay, that's great, we can absolutely do that, but let's like find out, let's do this contextual inquiry and find out what's getting in the way. And one insight that we sort of uncovered was this idea of a hot-cold empathy gap, as Jordan Bernstein calls it. So when the therapist is planning for the session, she's in sort of a cold state, right? Like calm, pretty rational, not very emotional, can sort of imagine you know, what she's going to do in the therapy session. But what she has a harder time doing, because we all do, is really empathizing with hot state her who's going to be in that session. So by the time she gets in the session with the patient, both she and the patient are likely to be tired, maybe a little sort of emotionally activated, maybe it's the end of a long day, maybe there are a lot of other fires to put out with that patient besides thinking like, okay, now I need to do step 3 in trauma-informed CBT right now. And that's a completely different problem from like, I feel undervalued when I do this, or I don't feel like my agency supports me in doing this practice. And the kind of design ideas you might come up with are really simple things like, you know, very salient, simple checklists that can kind of keep you anchored in the protocol as you're going through it, or post-session reflection prompts that have you think through like, oh, interesting, I had planned for this, but this is what happened. How might I do that? Sort of either eliminate the hot state nature of the visit or help cold state you plan for knowing if you're going to be in a hot state. Really different intervention idea from reducing incentive. Different context back in Peru we have really high rates of childhood anemia. And like a lot of countries, there's a micronutrient program to give caregivers and parents micronutrient powder to add to infant food, early childhood food, and pretty low adherence to that as well. So the parents receive it during like a well-child visit, and then there's just very low reports of like, I open up the packet during the mealtime and I dump it on the food and I get the food in the kid. You could think about sort of education campaigns, you could think about other ways of doing it. One insight we uncovered though was around mental models. And we could hear from interviews with parents and caregivers that parents who thought about it, whose sort of mental model for what this stuff was like, it's a multivitamin, had an easier time incorporating that into feeding routines than parents who thought of it as medicine or sort of a prescription. That just like, that proved to be sort of a facilitator, and that proved to be a barrier to sort of being willing to kind of go through the hassle. The kids don't like it and they spit it out and everything. But that mental model of like, oh, this is like vitamins was helpful. And that's informed sort of how we both think about counseling in the clinical setting when we give this stuff to parents, and also sort of framing the intervention. Different from just like, let's educate or let's provide. I have some other great examples if we have time to come back to them. These all came out of the course I teach in behavioral economics and health at Penn, mostly the Masters of Public Health students and Masters of Behavioral and Decision Sciences, and the groups do projects over the course of the semester and go through the nudge process. We get great stuff out of it, often helping students. So that's sort of design matters. And make sure you know if you're looking at cinnamon buns, what's important. Okay, let's talk about heterogeneous treatment effects. This is not going to be a surprise to anyone here. Interventions work differently for different groups. And sometimes we're smart and careful about thinking about ahead of time what we want to look for, and often we're not. And then we sort of want to go for like exploratory sort of fishing expeditions to see what we've got, and then we're not powered, and then we don't know how to talk about it in the paper. That's disappointing. And another way in which I think we're sort of leaving value on the table. So just a couple of empirical examples. This is an oldie but goodie from Rothman et al. On response to loss frame versus gain frame messaging to increase mammography take-up. And on the left side of the scale, so the gain message is in dashed line, loss message is in solid line, and the x-axis is the woman's perceived susceptibility to breast cancer. So how likely is it, how susceptible do I think? And at the low end, there's not much difference, basically no difference between the gain frame and the loss frame in probability of self-reported screening. Among the women with the highest perceived susceptibility, though, the loss message is doing a lot better, and the gain frame is actually doing worse than for the women with lower perceived susceptibility. So there's heterogeneity across that perceived susceptibility. If that wasn't something you'd analyzed, you can sort of do the math and see you'd probably sort of come out with like, gain frame, loss frame, not much difference. Okay. So how do we kind of pre-specify those both theoretically and then empirically? How do we make that in? This is a really nice kind of reanalysis of some data from a colleague at Penn, Scott Halpern, who's done a lot of large, very pragmatic incentives for smoking cessation studies. And they wanted to go back, ex post, this was not something they pre-specified, to see if response to either a straight reward, just kind of paying people as they were able to maintain abstinence, versus a deposit contract where they actually put their own money up front, which is sort of doubled by the program, and then that money's taken away if they smoke, that's a deposit contract, versus the usual care. If there were differences in response to those incentives by household income, and also by sort of credit worthiness, or sort of months in arrears that people were on their bills. And some interesting differences. I mean, we can talk about the details, but response to those three different interventions varied across the income scale and across the, we'll call it creditworthiness scale. But again, an ex post analysis. And finally, some interesting interactions between depression, present bias, so how impulsive or how now oriented are you versus future oriented, and smoking status in adolescence. That I think was in this paper was sort of pre-specified and looked at, and might point you to at least targeting, if not tailoring, of interventions as we think about the interaction of those three, those three conditions. Say being very present biased, potentially being depressed, and smoking initiation among adolescents. So like, how do we solve that one? I mean, I sort of said it a couple of times already. I think we can be careful and smart about pre-specifying them and thinking through, like, to understand this mechanistically and to understand subgroup effects. How do I need to power this? What do I need to measure and when? So that I can even ask these questions and hopefully answer them rigorously. But to me, I don't know, I try to think about sort of BE 1.0 was like, whoo, incentives, they work. And then BE 2.0 is like, there are a lot of other nudge options in the toolkit. I think 3.0, or maybe we're at 4.0, I don't know, is going to be about these sort of for whom do they work, when, what behavior, under what conditions. And we have to have the empirical chops to answer. All right, last bucket is around scale and implementation. So, this is where rubber meets road. We do these often pretty small, pretty, well-controlled, sometimes lab-based, sometimes, clinic-based or community-based, but pretty small trials. Stuff looks like it works. And then what do we do with it? Do we put it into practice? Do we recommend that this is now, the nudge that the government should use or this health system should use? And I think the approaches have been like, run a tiny pilot, and then if it's successful, try to scale it, right? Or run big trials from the get-go in very pragmatic settings. Our Chagas trial was like that. We basically sort of layered our interventions on top of an existing public health campaign and sort of hope for the best. But there's a lot that's not in your control, and you end up with a lot of null trials. And I'm sort of thinking about and wondering how we can, again, kind of go back to the design world or the innovation world and think about rapid cycle prototyping. Like, what can we learn? How can we learn, learn quickly, fail fast, even in a sort of scientifically rigorous way and well-powered and fundable stuff, to answer some of the design questions and also some of the sort of implementation questions early on, so that stuff is sort of engineered for scalability and for implementability from the get-go. We don't sort of hope that we run a small thing that maybe we could scale. We kind of build it for implementation and scale from the get-go. I don't have the recipe book for that or the cookbook, but certainly for our work with INDLELA, the HIV nudge unit in South Africa, and frankly for most of the stuff we do, that would be really helpful if we could do that upfront. I want to talk really quickly through just an example of how we might do that from some work we're doing with pregnant smoker cessation in Medicaid plans, state Medicaid plans. This is another thing where like stacks and stacks of Cochrane reviews say that financial incentives for smoking cessation are pretty much the most effective intervention during pregnancy for smoking cessation, more than any other psychosocial or sort of quit line support. And yet we have not been able to find a statewide payer or even a large health system that does this as standard of care. There isn't, like North Carolina Medicaid doesn't offer financial incentives during pregnancy for smoking cessation. Actually the state of Kentucky was interested in figuring out whether this should be part of their state Medicaid plan. Came to us to sort of ask, like, hey, why doesn't this happen? Could we just tell our payers, our Medicaid managed care plans to do this? And we sort of knew from prior research, but also did some discussions with the payers to find out what was getting in the way and stuff you'd predict, right? Like the schedule is already very complicated for prenatal care. There's a lot going on, a lot that has to happen. This isn't really top of mind for anyone. Just the mechanics of how you get incentives delivered to people becomes this like immediate brouhaha. Like, is it a Walmart gift card? Is it a $20 bill? Where does the $20 bill live at the clinic before we give it to the person? Can we give it to them 2 weeks later? Is that the same as giving it to right away? No, you can't. Like shockingly difficult. How we verify biochemically that mom's actually abstinent is an issue. Are we doing cotinine tests? Are we doing CO monitoring? Who does that? Do we have to do that? Can we just give incentives contingent on self-report? And then how does this get baked into the workflow of the healthcare workers? There were probably 10 more barriers, but those came up as a problem. So we tried to set up with one clinic and one payer a set of sort of rapid cycle pilots to try to answer some of those questions very differently from how we would, for example, do like pilot work for a research study. We didn't want to like figure out how this clinic could help us run another incentives trial. We wanted to figure out how we could get this clinic and this payer ready to actually run this as a program. The assumption is, the evidence shows it's effective. How do we do the implementation piece? So we did these very, very small, none of this, I don't know if this is publishable or not. If anyone is publishing suggestions, let me know. But these are tiny pilots like vapor tests, right, of demand. So handing out flyers that say, hey, this program's coming. Are you interested? Text us this number, and trying different versions in different language to see, like, is it the incentives message that gets people, or is it the, like, this is really good for your baby? And just, handing these flyers out for a week or two and seeing if people text us. And that was basically just to like see if there was demand. Figuring out the cotinine testing or the biochemical verification. In other studies we had done, the cotinine testing, this clinic happened to have a CO monitor lying around from another program. So like, all right, if you've got the CO monitor, we can do that too. That helps us figure out if smoking is happening or not. So running for a couple of weeks, just having women who reported smoking blow into the monitor. Was it easy for the nurse to do? Was it easy for the woman to see the results? Were the results making sense for her? And then, Kentucky, like many states, actually has an incentivized program, not for quitting, but for engaging with a quit line. So you can get, if you're a pregnant smoker in Kentucky, if you just call the quit line and have a conversation with a counselor, you can get incentives for up to 4 visits during pregnancy and 3 visits after, or vice versa. But no one was using that program. Like, they literally had no calls from the whole state. There were no calls from pregnant people. And we're like, this is like a resource we left on the table. So we thought, like, if we do a warm handoff, right? A lot of research on warm handoffs, where instead of the nurse just handing the person the flyer, they say, let's call right now. Let's get you hooked up. Let's get you registered for the program, and then the next thing, the counselor will reach out to you tomorrow. That actually turned out not to help at all, but an easy question. We could, instead of baking that into a huge randomized trial and then being like, oh, the warm handoff doesn't work, in 2 weeks we could get an answer that we did 18 warm handoffs and none of those people connected with. And the quit line reached out to all of them and none of them engaged with it. So helpful thing to answer quickly. And again, I just want to emphasize, these were not like, we do a lot of pilots to sort of get ready for our big trials. These are pretty different questions that we're trying to answer. Like, we could have just bought the gift cards and shipped them to the clinic in Eastern Kentucky. Getting the payer to buy those gift cards, send them to the clinic, agree on how those would be kept, like, that was the problem we had to solve. So those are questions around implementation of behavioral insights. I'm also really interested in the behavioral insights underlying implementation. So this is sort of a meta level, right? Can we think about the nudge toolkit being useful in implementation science? This is Byron Powell's very thorough catalog of implementation strategies. Like, what do we do in settings to get evidence-based practices into practice? Plan strategies, educate strategies, finance strategies. Is there an opportunity to bring behavioral insights to those strategies? Again, that sounds maybe sort of like a layer up from where we were talking, but we know that when organizations make decisions, when implementation projects happen, all the same biases, heuristics, rules of thumb, decision-making things that we look at in patients happen with providers and organizations and managers and programs too. And we can think about sort of organizations being present bias or having confirmation bias or attentional resource deficits. So I think that's like a whole, like we could do another hour-long talk on that, but I think a really promising space. And a paper that I recommend that I've been thinking a lot about takes us to the level of government policy making. This is the Behavioral Insights team, the original nudge unit, UKBIT, has this great report called Behavioral Government that says this happens at sort of policy level too, like when ministers or agencies sit down and try to make decisions about, how's this transportation project going to happen, or what should our Medicaid program look like. There are lots of biases at the organizational level happening there too, and we can probably make better policy if we pay attention to those as well. So again, sort of another level up, but a neat framework and worth talking about. Let me, I think, stop there and let's have a conversation. So what do you want to talk about?
Question with this research, is there like a general default bias that might be at play with like the basic design of a nudge?
Okay.
Just for elaborate, like a lot of the examples you present are kind of premised on individuals taking action to do something.
Yep.
And I guess that in and of itself could be viewed as an issue because some, on the subject of heterogeneity, some individuals are going to be in a better or worse position to take action on something, especially if it's health related.
Yep.
So I guess my question is, if action is like a core component of nudges, is that almost like a fundamental bias in and of itself?
Yeah, I mean, a couple ways to think about that. So, there are a lot of nudges and nudge approaches that try to like remove that action step from someone. Like, can we like eliminate a bunch of actions that someone has to take? Defaults do that, right? And I think when we do the nudge process, one thing we try to do at that D stage when we're kind of generating the sort of discoveries and the insights is generate a bunch, like dozens. And we know like some of those are true for some people, they're hypotheses. Some of them are true for some people, some of them are true for others. And which ones sort of bubble up in a rapid validation process is being pretty true for a pretty good chunk of people that we might want to test it with. With something like the therapist interventions that we're trying to do, we know, for example, that some of the nudge designs we came up with are likely to get better with, for example, new therapists versus those that have been in practice for a long time. And that helps us set up a trial where, we know that time in practice is going to be one moderator of a treatment response that we know we want to take. Because their decisions are different, the decision context is different. The other thing that your question made me think of, also from the UKBIT, someone read their EAST report, the EAST framework. So they had this framework called Mindspace, which was just like too many letters to remember what everything stood for. So they made it a little easier and boiled it down to EAST, which is just easy, attractive, social, and timely. 4 buckets under which a lot of nudge approaches can be sort of parked. And of the 4, we know that like making things easy is sort of at the top of the list. So again, like it's hard for someone to think through an action and take the steps. And if we can like just remove a bunch of those from the decision, we're likely to get that. Sure for these. Very helpful. Yeah.
So I'm wondering a little bit about how you deal with the populations who you design interventions for, and thinking about like issues around perpetuation of power dynamics, and that you're likely targeting vulnerable populations, and then you're kind of modifying behavior explicitly. And that feels like a little bit of a murky space as a social epidemiologist like that.
Yeah, it's a really, really good question. I have a couple of thoughts there. One, the first thing that came to my mind, I have a doctoral student at Penn nursing who's really interested in these approaches. She's a mental health nurse practitioner. in addition to a doctoral student, and was really interested in providers' perceptions of the ethical acceptability of nudges being an implementation predictor. So if I pitch you as a clinician group, like, here we have these cool nudges for your patient population, is there sort of a like, ew, no, like I'm not gonna, that's not, like I'm gonna talk to my patient and find out what their needs are and come up with a solution that works for them. I'm not gonna like nudge them. And it turns out that that's very salient for a bunch of clinicians. I would say more so in nursing than in medicine, but that they are very worried about perpetuating the dynamic. I guess the other response I would have, and Sunstein and Thaler bring it up too, like our choice architectures are already architected. Like they exist. So, you know, when we change them, sometimes there's attention paid to the new thing that we're doing. But there's just a lot of implicit architecture in the choices that we make already. So, you know, I think we have to be extraordinarily careful about, you know, perpetuating, as you said, sort of power dynamics and being sensitive to the fact that these are vulnerable populations. That comes in the size of the incentive, what we're incentivizing. People are often, for example, okay with incentives for smoking cessation, not okay with incentives for anything around contraception. Like, nope, we're not doing that. And even in smoking cessation, we get arguments like, why should one group that's smoking get paid? And here I am, I've been smoke free, you know, either forever or for 20 years. No one's going to pay me to like stay smoking. That's not fair. So there's a lot of sort of fairness arguments. But you know, I think if we lead with, you know, we want better population health outcomes. Often nudges work best when there are behaviors that people already say they want to take up. But I think one of the reasons we kind of hit the wall with the Chagas project is like no one really cared about Chagas disease prevention, and actually they didn't see a lot of cases. They didn't know anyone who had the disease. A lot of them didn't even see the bugs in the house. But for something like weight loss or diabetes prevention that they're pretty salient for folks, they're often looking for solutions that will help them reach those goals. And there isn't good evidence on whether sort of placebo effects, not really placebo effects, but it doesn't appear that nudges work less well when people know they're being nudged. So it's an interesting space as well. Like once we tell people they're being nudged, does that ruin the effect? It doesn't look like it does, but more time.
Yeah, just kind of following up on some of the ethics issues.
Yeah.
I'm kind of thinking of a case of a program we were evaluating where it came up. They were using, it's HIV related in Africa. They were giving people like a white water jerry can if they came back and got their ARTs several times. And everyone started to figure out that if you got the jerry can, you were HIV positive. How often are those kinds of things? Did you have any kind of experience or observations on those kinds of unintended consequences?
Yeah. And that just seems to be like a really bad design.
Yeah.
That someone should have caught. Yeah, and I think you know, prototyping can help with that. Like you don't want to get a third of the way into a large trial and figure out that that's a problem because you just killed your trial. But some savvy prototyping can do that. We had in the Chagas project, houses are actually marked once they're sprayed. They have to get sprayed twice, and they get a little vertical line the first time, a little horizontal line the next time, so you can see like this house has been sprayed or not. So that information is already there. But we were trying to think about making participation more salient. Like we wanted neighbors to see that their neighbors had participated. Like balloons or one of those thermometer things. And one of the issues that came up was people worried that visible signs of participating were stigmatized, might be stigmatized because agreeing to spray probably meant you had bugs. We know that households that like can see that they're infested are like, come on in and spray. Whereas other households are like, I don't have bugs, you don't need to spray. We're like, you still need to spray. Like, no, spray. And that being more visible would make people really, really nervous that they were like, I'm in the dirty, gross house with bugs. But I think you can only uncover that with really good, whatever, contextual inquiry, formative work, talking to stakeholders, and just try to avoid a lot of assumptions mapping. And try to pay a lot of attention to the assumptions where it's a deal breaker if we're wrong and we have no idea what the answer is. Like the other quadrants in that 2x2, you don't have to spend so much time with, but like let's debunk those sort of high risk assumptions so that we don't end up in a dumb design space. Bring designers on your team. That's like the one takeaway from this talk. Bring designers on.
Yeah, okay, I have lots of questions. There's one, do you have some good examples to give of like large scale nudge programs that have been implemented and are working and running like efficiently?
Yeah. So the US one that comes to mind is kind of the same or a prior study to Scott Halpern's heterogeneous treatment effects that I showed you. So Scott and colleagues ran a 5,000 person, I think, randomized trial of like $700 to quit smoking, and it was with CVS employees. So that was the group, and I think that paper was published in Journal of Medicine or something. And like the next day, CVS announced that like that was what they were doing now. That was their employee cessation program. They called it 700 Good Reasons to Quit. It's still going on. It's still being evaluated by CHIVE. And it was, I think, we sort of put the New England Journal paper in that story, but I think CVS had obviously already decided that there was good enough evidence that they were already spending a lot of money trying to get employees to quit smoking, that was enough evidence to just go with it. A lot of negative stories. I mean, the Ministry of Health in Peru was very, very open to working with us in trying these different approaches. They really didn't want the lottery to work. They thought like, uh-oh, if it works and it works really well, we're just nervous about implementing that on an ongoing basis for two reasons. One, we don't think we're going to have the resources, and two, they were really worried about motivation crowd out. You asked for a good example, I'll give you a negative example. But the motivation crowd out story is interesting. Like, if it's just known that there's this lottery incentive and you can get money for participating in the Chagas campaign, then whenever we ask them to do the next thing, they're going to say, where's my lottery? I'm not doing it. And we actually built into that trial looking at subsequent related behaviors like getting your dog vaccinated in the rabies campaign. And interestingly, we did see motivation and crowd out for the second round of spray. So if you got a lottery incentive the first time, you were actually less likely to participate the second time without the incentive. But we didn't see anything like that for sort of less related behaviors like surveillance activities for Chagas and for rabies. So the scale questions are huge. Yeah.
Thanks for a great talk. So the question I want to ask is about wealthy, powerful people.
Okay.
And nudges. Can you think of successful interventions among the powerful and wealthy where nudges have been tried or that they work?
Where it's the wealthy and powerful being intervened upon?
Yes.
I don't know if this is going to fit your criteria or what you have in mind, but two slides I didn't show you that almost always come up in nudge talks are organ donation, right? The power defaults to drive organ donation. And they show you 8 or 10 European countries, and the 3 countries where you have to opt in to be an organ donor have really low rates, and the 8 countries where you have to opt out, basically the default is that you're an organ donor have like 97%. Those countries are full of wealthy, powerful people. I don't know if we would see like within country differences in those effects, but in terms of sort of high-income countries with lots of less powerful people, defaults work great. The other slide that you're often shown is on retirement savings, right? So whether you're a frontline worker in a lower paid job or you're an executive, when you sign up for your company's retirement plan, the default amount that they set to be your payroll deduction for retirement is what 95% of people stick with. Of course, you can say no, I don't want to contribute anything, or I want to contribute 10%. But those defaults are sticky across every employee group and employers. I think these guys are probably getting at it best in terms of like working with ministry, sort of high-ranking health ministers making, or any sector of ministers making kind of big decisions. And I love that they are saying, there's biases going on, when you are setting an agenda, and there are biases going on when you are making analogies that this is things like this other thing. But there's not a lot of empirical work around that. I think we're out of time. Yeah. I'm happy to sit around and chat, but thank you so much, especially given the weather. I really appreciate the audience.